Good evening, and thank you so much for joining us tonight. I'm Dr. Maria Anderson, and I'll be talking about atrial fibrillation, what it is, what things you can do about it, and how we treat it. First of all, I'll introduce you to our Atrial Fibrillation Clinic at Boulder Heart. Our goal is to provide evidence-based, compassionate care and help manage this complex, often very bothersome arrhythmia. We want to look at the whole patient, all the medications we can use, all the things you can do in your lifestyle, attend to all the psychological impacts that this rhythm can have, and go over the state-of-the-art procedural treatments we have for atrial fibrillation. It takes a village to run an atrial fibrillation clinic. We use and interact with tools and folks in radiology, in primary care, in the emergency department, the cardiologists who focus on things other than atrial fibrillation. We work with pharmacists who help us manage medications and keep people's blood thin to prevent strokes in atrial fibrillation, as well as lung specialists who help us with sleep-disordered breathing, which can also play a role in atrial fibrillation. So it's a multidisciplinary program that we've put together with a lot of interactive communication amongst the groups. First, I'm going to start with what can you do about your atrial fibrillation. We're going to go over a lot of information tonight, and at times it might seem overwhelming, so we'll try to break it down into manageable bits. Often when people are diagnosed with atrial fibrillation, it's very frustrating to hear. They feel they may have done a lot of good things in their life, and yet now they're saddled with these episodes of palpitations and rapid heart rhythm. Well, I want to go over that there are many things that you can do from a lifestyle perspective to help improve your freedom from atrial fibrillation, to prevent it from progressing from episodic, or what we call paroxysmal, to persistent or long-lasting. Also, if people need to undergo procedures for atrial fibrillation, lifestyle measures can make those procedures more effective. In addition, lifestyle measures can decrease the risk of stroke. So there have been a variety of articles that have been published over the past decade or so going over what those lifestyle measures are that folks can take for themselves. This is a summary of one study that was published about 2 years ago in the journal Heart that found these 5 studies, which were randomized control studies, found that when lifestyle measures were undertaken to reduce a person's waist circumference and weight, or body mass index, that decreased the amount of atrial fibrillation folks had and how severe and long-lasting it was. Another study found that folks who undertook lifestyle measures for their AFib greatly boosted the success of atrial fibrillation ablation from about 33% to 87%. We also found in 3 other similar trials where weight loss, just even less than 10% of weight loss, or slightly more than 10% of weight loss, of body weight loss, greatly increased well-being and freedom from atrial fibrillation. So what are those factors? Folks who have obesity and physical inactivity, weight loss of 10% or 10 to 15% of body weight is shown to improve atrial fibrillation. Those who have high blood pressure have more atrial fibrillation than others. Sleep apnea, diabetes, high cholesterol, alcohol use, and smoking all greatly contribute to atrial fibrillation through a variety of mechanisms that we'll talk about. Now, the standard Western diet, unfortunately, increases atrial fibrillation, and does that in multiple ways through creating inflammation, damage to blood vessels, raising the glucose levels in the blood. Standard Western diet is an omnivorous diet that consists of high fat, often excessive protein, and high carbs. And a lot of processed food, unfortunately. And that's the worst case scenario for what a person can eat leading to atrial fibrillation. On the other hand, data show that a whole food plant-based diet improves atrial fibrillation. It lowers inflammation throughout the whole body, including in the heart. It heals blood vessels even after they have some degree of blockage or atherosclerosis. It regulates blood sugar and can reverse type 2 diabetes, and it decreases the amount of fat on the surface of the heart. Excess weight, as we've mentioned, increases atrial fibrillation, in part because when a person has increased weight, they also have increased amount of fat on the top of the heart. It specifically will lay on top of the atria or upper chambers. This fat, what we call epicardial fat, drips inflammatory chemicals onto the heart chamber and increases atrial fibrillation. Excess weight also increases sleep apnea and high blood pressure, and as we've mentioned, losing even 10% of body weight improves atrial fibrillation. This is one study about epicardial adipose tissue, what is abbreviated as EAT. This fat, normally everyone has some fat on the surface of their heart, but when it's excessive, then that creates inflammation in the heart and specifically contributes to atrial fibrillation. This is a diagram where on top of the left atrium, this epicardial adipose tissue builds up, and it releases a variety. They're all sort of listed here. They all have abbreviation, confusing names, but these are all inflammatory chemicals on the surface of the heart that create scarring of the heart and that sort of inflammation that then contributes to AFib both starting and progressing. It's like a sponge, this epicardial adipose, just dripping inflammatory chemicals. Smoking is also a very important risk factor for atrial fibrillation that can be modified. It magnifies by a factor of 5 the likelihood of getting atrial fibrillation and further increases the risk of stroke, which folks with AFib unfortunately have an increased risk of stroke. Those who also smoke have a much higher risk of stroke. It does that by damaging heart cells and blood vessels and again creating inflammation. Unfortunately, I have to share that alcohol increases the risk of atrial fibrillation. We know that even 1 drink a day increases the likelihood of developing AFib, and a recent study found that after 1 drink, just 1 beer, for example, for the next 4 hours, a person is more likely, much more likely to develop an episode of atrial fibrillation than those who don't drink alcohol. Exercise has a close relationship with atrial fibrillation. The ideal amount of exercise is 150 to 300 minutes per week, and that's the least associated with atrial fibrillation. It's this baby bear zone where there's not too little and not too much. Now, at the extreme ends, folks who don't exercise at all, or folks who exercise very vigorously, highly trained athletes, people who exercise 10 hours or more a week, those folks have a lot of atrial fibrillation. This is what we will call a U-shaped curve. At the one end, folks who don't find themselves able to exercise, it's often associated with excess weight, higher blood pressure, and so as you increase your amount of exercise, the rates of excess weight, high blood pressure, diabetes all go down. But as you get farther on the end of exertion per week, it can actually cause little bits of damage to the cells and scarring of the heart cells, increased pressure on the upper chambers of the heart, and increases the risk of atrial fibrillation as well, unfortunately. Stress plays a large role in atrial fibrillation. It's a vicious cycle. Atrial fibrillation itself is a cause of stress and feels a lot like stress feels on the body. Both physical and emotional triggers can lead to atrial fibrillation. But then the other end of it is that stress, physical and emotional, can then trigger AFib. They can both trigger each other. Exercises like walking, hiking, various forms of meditation are all shown, thankfully, to decrease your likelihood of atrial fibrillation. Sleep is critical for atrial fibrillation. Those who have 7 to 8 hours of sleep per night have the least atrial fibrillation. And those who have poor sleep quality, or especially obstructive sleep apnea or central sleep apnea, have a greatly increased risk of atrial fibrillation, and the presence of sleep-disordered breathing greatly decreases the success of the procedures that we do to treat it. Alcohol use, excess weight, and stress, factors we've already talked about, further increase or worsen sleep quality rather, so they have this kind of interconnected role to play. As I mentioned, sleep apnea is a major cause of atrial fibrillation, and of all comers, people who come to our atrial fibrillation clinic, about 85% of them have some degree of sleep apnea. Now, if sleep apnea is present, but it's not treated, the success of our atrial fibrillation ablation decreases from about 70% with one procedure to about 50-50. In addition, people with sleep apnea have a greater progression of their AFib from episodic or coming and going to lasting, which is harder to treat. The most effective treatments for sleep apnea are weight loss, if that's relevant to the individual person, and CPAP, which can be provided by a sleep specialist. Now, this is a very busy slide, but it points to the fact that all these risk factors and lifestyle modifications are things that you can do for yourself to help decrease atrial fibrillation. So in conclusion, as far as weight goes, many people don't sort of believe in their weight as the only trigger or their body mass index. So when folks are curious about that, what I say is, once your weight is at a point that your waist is smaller than your hips, then you're likely at your goal weight. Eating a diet that's high in plant foods and low in processed foods is associated with better atrial fibrillation control. Quitting smoking, avoiding alcohol, reducing stress if it's possible, and considering meditation, as well as moderate exercise, about a half an hour to an hour 5 days a week, is the ideal lifestyle combination to decrease your likelihood of atrial fibrillation. And taking a dog out for a walk, as many of us do, is also decreases atrial fibrillation by decreasing stress and increasing our exercise. So now I'd like to transition from the things that each individual can do to what we can offer you to help treat your atrial fibrillation. We'll go over the basics of what atrial fibrillation is. We'll talk about the two ways that we treat atrial fibrillation, rate control and rhythm control. And for each of those, we'll talk about medical versus procedural treatments. So what is atrial fibrillation? Well, as you know, the heart has 4 chambers, 2 upper chambers called atria and 2 lower chambers called ventricles. Normally, the upper chamber should beat in an organized way where the heartbeat comes from one place and radiates down from the top to the bottom chambers. In atrial fibrillation, there's just complete and utter chaos in the upper chambers. And this is actually a diagram of electrical activity progressing across the upper chambers in atrial fibrillation. It's just complete chaos. Now, the consequences of atrial fibrillation are several. The EKGs are how we diagnose atrial fibrillation. On the left, this is normal rhythm, where the top beats, then the bottom, the top, then the bottom. On this side, we don't see organized activity in the top chamber, and the bottom is erratic and fast. There's no pattern to it. Here you see a picture from heart surgery, and on top, you see the atria sitting on top of the heart. And this is what atrial fibrillation looks like. It's just shaking completely chaotically. Over time, atrial fibrillation without treatment of lifestyle, medications, or a procedure progresses. And the way in which it progresses is that at first, folks have episodic atrial fibrillation that may come and go. It could last a few minutes, a few seconds, a few hours. Over time, people tend to develop episodes that last until we do something. Well, one of those things we can do is cardioversion. It's here delineated as CV. Now, it's important to know that cardioversion is an in-the-moment treatment. It's geared at resetting someone's heart in that moment. It does not keep people in normal rhythm. If people's hearts are not going to go back into atrial fibrillation because they haven't been stretched out or scarred over time, a person may have a cardioversion and it might last for months or a year. Other people, though, we do a cardioversion and they go right back into atrial fibrillation. Along with this progression of atrial fibrillation from episodic to requiring cardioversions and interventions and lasting longer and longer, we see that in the heart, the atrium start to stretch out, become larger, and can become scarred as well. And then, in another vicious circle of atrial fibrillation, the more remodeling and scar that happens in these atria, the more likely it is to be able to sustain atrial fibrillation. So, as we say, atrial fibrillation begets atrial fibrillation. There are multiple risk factors for atrial fibrillation. Some of them include folks who have a weak heart, who develop heart failure, people whose heart valves are abnormal, they get a lot of excess pressure in the upper chambers that contributes to atrial fibrillation, and folks who've ever had a heart attack get more atrial fibrillation. There are many common features, risk factors for atrial fibrillation, especially high blood pressure, as we've talked about, diabetes, and sleep apnea. Things like an overactive thyroid can cause atrial fibrillation, so typically, and often even before they see us in cardiology, folks are screened to make sure they don't have an overactive thyroid causing it. Those with lung disease have more atrial fibrillation. Again, that puts pressure on the heart, and that can increase AFib. And people who use stimulants such as cocaine or methamphetamine, as well as we've talked about, alcohol, get more atrial fibrillation. Atrial fibrillation can also occur after the stress of a surgery or the stress of an accident, and when that happens, it doesn't necessarily predict that people will have ongoing atrial fibrillation. There's two ways of treating atrial fibrillation. One is what we call rate control, and one is called rhythm control. Rate control means allowing someone to be in atrial fibrillation, but when they go into it, whether they go in and out of it or whether they're in it all the time, we use medications or a combination of procedures to prevent it from making the ventricles, which is the pulse, which is the heart rate, go too fast. The atrial fibrillation just does what it wants. These kinds of treatments don't impact what the upper chambers are doing. It just controls the bottom chamber's response to it. It's an uncomplicated way to treat AFib, but most people feel best when they're in normal rhythm, so we don't usually start with slowing things down alone. Rhythm control, on the other hand, is getting people back to normal rhythm and then keeping them in normal rhythm. It directly addresses the atrial fibrillation, which can help prevent it progressing over time, and it directly treats the symptoms that come from the AFib itself, not just from the heart's response to it. We can use medications for this. These are antiarrhythmic medications. There's a handful of these, about 5 that are commonly used. They all have pros and cons. They can be hard to take and can potentially have side effects that are within the heart or outside the heart. And it's a very individualized decision that when I sit down with someone with AFib, we go over the ins and outs of those medicines. We can also do the procedure called ablation. Both of those, medicine rhythm control and ablation rhythm control, are designed to suppress the triggers of AFib and keep the AFib from happening. So choosing between rate and rhythm control is a complex thing, and that's one of the things at the AFib clinic that we do every day. Sometimes people may, when they're in atrial fibrillation, we can use rate controlling medications to just slow it down and ease the symptoms until we can get them to the point that we can restore the rhythm to normal. Folks, there are occasionally people who have atrial fibrillation who, as long as it's not going too fast, they feel fine. They're not limited by it, and they don't mind having atrial fibrillation. It's not interfering with their life or their exercise, etc. And those people may be great candidates for just controlling the heart rate in AFib alone. But in most people, they're fatigued or they feel palpitations, they feel their chest racing, they feel lightheaded when they're in AFib, and those people do much better with rhythm control. Often people come to rate control when they don't feel the atrial fibrillation, or they've been through many treatments for rhythm control and they can't tolerate those treatments, or for some medical reason just can't undergo those rhythm control treatments. So the rhythm control options, first we generally start with antiarrhythmic medications. As I mentioned, there's no perfect one of these. There's a handful of them available. There aren't hundreds of medications like this. The most effective medication is amiodarone. However, it's also the rhythm drug that has the most side effects. It can build up in a person's lungs, thyroid, liver. And so often we'll use this for a brief period. Say someone has had atrial fibrillation caused by a recent surgery. We might use amiodarone for 3 months or so and then see how they do. And people tend to tolerate it for that. But when folks are on that medication for decades, they're likely to have one or more of side effects from amiodarone. There are several other options, some of which can be started in the clinic and just require a periodic EKG. Others of which require that you come into the hospital and stay with us for 3 days in the hospital while we monitor the person's EKG to make sure they're not having rhythm problems from the medicine while we're trying to solve other rhythm problems with it. All rhythm medications can have what we call proarrhythmia, where the medications can bring out other rhythms that we don't want to see while we're trying to suppress atrial fibrillation. So there are a lot of things that we go over when we offer people rhythm drugs about what side effects they might have and what kind of screening they might need after they're on one of those medications. Dronedarone is a medication that was designed to have fewer side effects than amiodarone, but it works similarly. But unfortunately, it's the least effective of all the medications, so it's actually not one that I usually prescribe. Ablation is the procedural rhythm control treatment for atrial fibrillation, and of all the rhythm control treatments, of all the medications and procedural options, atrial fibrillation is the best, statistically most successful treatment for atrial fibrillation. What we do and what the mainstay of this ablation is this. Atrial fibrillation generally originates in the veins that bring the oxygenated blood back from the lungs into the left upper chamber. Essentially, electrical sparks come from these veins and then start triggering the upper chambers to just shake chaotically. So the main thing we do with atrial fibrillation is to keep electrical sparks in the veins from jumping into the left atrium. When people have atrial fibrillation that comes and goes, what we call paroxysmal, atrial fibrillation ablation, we will quote people about 70% likely to control their atrial fibrillation long term. In people who develop that atrial fibrillation that they're in it all the time, this ablation comes down, the success of it comes down to closer to 50 to 60%, depending on the person's individual situation. So we prefer to offer this earlier in the course of atrial fibrillation because it's more successful at that point. Now, of course, a procedure has upfront risks of any invasive procedure. It's done under general anesthesia. We have to access the person's heart through their bloodstream. And so we're very mindful of things like bleeding and clotting and collateral damage to other structures in the heart. So there's an upfront risk to it. Whereas the rhythm drugs for rhythm control, those medications have more long-term risks because of proarrhythmia, as we've talked about. So ablation is performed as I mentioned, by accessing the person's blood vessels, the veins, and we snake wires up into the heart, and those wires go from the right upper chamber into the left upper chamber, which is where those lung veins drain. We can use either a balloon that sits at the entrance to each of these veins, one by one, and freezes along the entrance, which will prevent electrical signals from jumping into the heart. Or we can use heating, where point by point we heat and essentially make a circle of heating lesions. So it's almost like building an electrical fence of sorts around these entrance to these blood vessels, which then prevents electrical sparks from the veins from jumping into the atria. We call that pulmonary vein isolation, and that's the mainstay of AFib ablation. This is a picture that we use of our three-dimensional mapping system that helps us draw a detailed anatomic picture that also will map out all the electrical signals of the heart, which we used to have to sort of just visually keep track of. And this computer software keeps track of all those electrical signals and where the veins are in space, so we can rely less on things like X-ray. We can use very little X-ray during this and just use this system, this mapping system. These red dots here are when we put these heating lesions on the blood vessels. These are the pulmonary veins, and this is where the pulmonary vein becomes the left upper chamber or left atrium. We encircle these veins with these heating lesions so that electricity can't flow from the vein to the heart or vice versa. Here, we use this color system, and we see that there's red here, and it's not passing into the heart after we do an ablation. So how effective are these options? Freezing the heart entrance of the blood vessels or heating work pretty similarly, and we quote people about 70% freedom from atrial fibrillation over the ensuing several years. Medications, this one study found about 7% likely freedom from atrial fibrillation over about a year and a half. Other studies show that medications work 40 to 50% for about a year. And for the most part, people need to have changes to their medications if they're on them, or dose increases, and fully 50% of people wind up stopping one or more rhythm drugs because of various side effects. That said, there are some people who tolerate one medication very well, and it may suppress their atrial fibrillation for decades. So each individual has a different situation, and we go over those details with them. So in summary, we're really grateful to be able to bring you community awareness of this particular heart disease. And if you have friends or family who are suffering from atrial fibrillation, have them get in contact with us. We have a lot of tools to help you address these challenges. Now, if you yourself are experiencing palpitations, again, give us a call. Letting it go, the longer people go with atrial fibrillation, the more challenging it is to treat and the more symptoms folks suffer. Thank you so much for your time and attention, and I'd like to now introduce Dr. Srini Iyengar, who'll talk about procedural methods of preventing stroke in atrial fibrillation.
All right. Well, thanks, folks. Appreciate everyone checking in tonight. I know we'd like to get everyone back live, but this virtual setting has worked as well. And thank you, Dr. Anderson, for that introduction and having her set the table for the description of atrial fibrillation and what causes it and how do we treat it. So I like to look at it from a perspective of, if you want to break it down in layman's terms, Dr. Anderson is the electrician and I'm the plumber. As an interventional cardiologist, I don't do any ablations of these rhythms, nor do I really understand sometimes what I see up there with those marks of the different ways, the pathways AFib travels. More simplistic here, I look at the pipes that go to the heart and come out of the heart and what's in the pipes. So what's in those pipes or in the heart sometimes is not good. We know blood runs through the system, arteries and veins, and through the heart. but we also know that things can happen in the arteries and veins, can lead to clotting. So something like that nature is what I want to talk to you a little bit more tonight. So first and foremost, as Dr. Anderson clearly stated, atrial fibrillation, irregular heart rhythm. Basically, the top parts of your heart are not really contracting normally, and the bottom is trying to pump the blood out of the heart. So what does that result in? Well, as she mentioned, the symptoms are shortness of breath, lightheadedness, and palpitations are quite common. We've already talked about some of the causes, but to reiterate, high blood pressure, coronary disease, which is heart attacks, abnormal heart valves, or heart defects you're born with, or even an overactive thyroid gland or exposure to too much alcohol. So the diagnosis, I can't tell you how many patients come to the office and say, I think I'm in AFib. And I'll say, why is that? And they'll say, well, I have an irregular pulse. Actually, the irregular pulse does not mean you're in AFib. It just means you have an irregular pulse. It could be caused by a number of things. So an ECG or EKG is mandatory. Not every irregular heart rhythm is AFib. PVCs, which are extraventricular contractions or extra atrial contractions, and APCs can all mimic feelings of AFib. So we talked about treatment, medications to control heart rate, antiarrhythmic medications, and as well as cardioversion, which can be done electrically or chemically, which can all control the actual rhythm of atrial fibrillation or the rate. Ablation, obviously, as just mentioned, has a high success rate and can also be utilized. But understand that these therapies are for the underlying rhythm for atrial fibrillation to control the symptoms related to this rhythm. So if someone then comes to the office and says, I don't even know I'm in AFib, I didn't realize it, no one's ever told me that until I got this EKG, that's when we're concerned even more. Because there's a lot of people out there who are walking and talking who have AFib and may not know it or don't feel it. So those are the patients where there's another issue that comes into play, as well as the patients who have AFib that feel it. So what else does AFib cause? Stroke. So when you see those commercials for those popular medications, Eliquis, Xarelto, there's a reason why they're showing you that elderly individual playing with their grandkids and running out in the field. Well, the reason is because AFib has a tendency to cause clot to coagulate or blood to coagulate and cause clot. There's a part of the heart called the left atrial appendage. I honestly feel like when I talk to people about this, it's like the appendix in your GI tract. Maybe millions of years ago it had a point, but right now it's only there to cause trouble. The appendage, which is in the left atrium, can collect blood and form clots that can break free in patients with AFib. So that's why one of the main reasons we place patients in AFib on blood thinners. So when people say, I have AFib, why did you put me on a blood thinner? This is the drive for it, because we know that clot can form in the heart, and well over 95% of clots in AFib develop in this appendage coming off the left atrium. Blood thinners. So what are we talking about in blood thinners? Warfarin or Coumadin, which is interchangeable. The new ones, the Eliquis, the Xarelto, the Pradaxas. These are medications that patients take to prevent blood clots in atrial fibrillation. So they work very well as long as you take them. And again, there are side effects that are seen. So warfarin or Coumadin is cheap, but a lot of people have trouble keeping their numbers within the range. So anybody watching who takes this medication knows you have to get something checked called an INR, which basically means we need to keep your levels between usually 2 and 3. But a number of things can throw it off, whether it be diet or other medications. The NOACs or the DOACs are the ones I just mentioned, the ones you see commercials for, are costly, and they lack readily available reversal agents. And again, these are blood thinners, so if you're bleeding, they can make it a lot worse. So we know AFib is a growing problem associated with greater morbidity and mortality, higher stroke risk for older patients and those with prior stroke. 15 to 20% of all strokes are AFib related, and it results in a greater disability compared to non-AFib related strokes. So we do know that with all the possibilities of stroke, all the things that can happen, because people always ask me, well, you know, I had a heart attack, but I recovered and I feel fine now. Well, I can't say the same for stroke. So if you look at this graph here, there's so many different areas of the body that can be affected by stroke because the brain is complex. There's not one particular artery that I would tell you in your brain that you don't need. Not that in your heart you don't need it, but the heart is a beautiful organ that can reperfuse itself and recreate some of the function that was lost during a heart attack. The brain, maybe not so much. And there's areas here where, again, I would tell you, there is no such thing as a good stroke. So the guidelines, which has been updated since then, but since the last 8 years, have shown that we really do need to be very proactive in prescribing anticoagulants to patients with atrial fibrillation. We use something called a CHADS VAS score down there. And basically the C stands for congestive heart failure, the H for hypertension, A for 2 points is the age of greater than 75, the D is diabetes, the S for 2 points is for stroke, the V is for vascular disease or peripheral vascular disease, A is for age of 65, which gets 1 point, and the S in the lower C is for gender, for females who get 1 point. So the truth is, this score is calculated by every single one of us at Boulder Heart when a patient comes in with atrial fibrillation to determine the likelihood or the probability of higher stroke risk. So at this point, you can see the score of 1 is between an aspirin and a warfarin or aspirin and anticoagulation. The guidelines are shifting. Now, more and more people are pushing towards saying if you have a risk of 1 or greater, go on a blood thinner. This is the issue though. Blood thinners carry risk. If you're on a blood thinner, I've had hundreds of patients say to me, I was just walking by and I bumped my elbow against the wall. The next morning I woke up and I couldn't even move it because there was a big, big bruise. How did that happen? Well, if you bumped your elbow, normally maybe you'd have a little bruise, but on a blood thinner, you don't stop bleeding. That's the whole purpose of a blood thinner, is to prevent clotting. And these are just examples, gross examples of the brain. If you had a bleed in the brain, if you hit your head on a blood thinner, they could be catastrophic. So like I mentioned, that CHADS VAS score is something we use to calculate risk for patients who basically have atrial fibrillation. So this score is not used for patients who don't have AFib. If you have AFib, we then calculate this score. And again, 1 or greater now, we're pushing for blood thinners. This is called a has-bled score, where we validate whether or not, what is a patient's risk of bleeding. So we will utilize this as well in conjunction to the first score to figure out, should you get a blood thinner? And if you are on a blood thinner, what is the risk then after that of bleeding eventually? So this is the issue. When patients say to me, well, you know, I've never had a bleeding episode, so I don't mind being on a blood thinner. Perfect, no problems. But this graph or this slide shows you bleeding risk will increase over your lifetime. It happens to all of us. Initially, people say, well, you know, I've never had a nosebleed or any bleeding from the GI tract. Well, guess what? It does increase over time, and that's just the human anatomy. And the truth of the matter is, once bleeding risks start increasing, obviously being on a blood thinner makes things worse. And this is just showing you that obviously at the 10-year bleeding risk with a has-bled score of 4, it's getting pretty up there. So again, let's go back to the treatments of blood thinners. They work, but warfarin or Coumadin, you have to keep it in its range. And 2 to 3 is the accepted range for atrial fibrillation patients. But here's the trouble. Majority, or not majority, but nearly half of patients who are on Coumadin fall below the level adequate. I can't tell you how many patients have come to the ER with the stroke from AFib with an INR of 1.9. So I will tell everybody watching at home, just because you're at 1.8 or 1.9, but today you're 2.4, it's not an average. You need to be above 2 consistently. But then you can see 44% of patients are higher than 3. And that's equally, if not worse, because when you're that high, any little thing can cause a major bleed. The problem too is patients don't like being on warfarin or Coumadin. I know someone at home probably is saying it right now, that rat poison. Well, it works, and yes, maybe it was back in the day for it, but right now it is a medication that does work effectively, but nobody likes taking it. So there's a problem. So then these new medications, the Eliquis, Xareltos, and Pradaxis came out, and we saw, wow, we can actually get patients on these medications easier because they don't want to have to check their levels. But even with these medications, the bleeding risks were there, and the cost, oftentimes insurance won't cover these medications if you can take Coumadin. So despite the adoption of these medications and ability to switch, people tend to not want to be on potent blood thinners for their entire life. It's a fact. So we have had to struggle as physicians of how do we get patients to take these medications but still deal with the major bleeding rates seen with them, nearly 3 to 4% per year with all of these types of medications. So we know AFib is a growing problem. We've already talked about the stroke risk with it. We say 90%, if not greater, of clots formed in the left atrium come from the appendage. Our current treatments with blood thinners are effective, but a lot of patients stop taking them or don't want to be on them. Anticoagulation bleeding risk compounds over time and may not be a viable solution in some patients. So this is important because, again, the bleeding risk is real, and especially if there's lifestyle attributed to increasing bleeding risks. So we should talk about, okay, well, what do we need to do about this then? Well, look at the bottom right, that graph, that little picture. What you can see there is where my arrow is the clot in the appendage. And what you can tell there is that realistically, that appendage with the clot is where we want to get rid of. We don't want that thing in that sac. So between the rock and the hard place of blood thinner and bleeding or no blood thinner and stroke came the Watchman device. So the Watchman was developed with this particular issue. There were so many patients out there who have fallen, who have had prior bleeds or active bleeds, whether it be nosebleed, GI bleeds, or patients who have active lifestyles, patients who feel like, hey, I go mountain biking every day and I go down really fast, and if I fall on a blood thinner, it could be game over. So these are important things that came into play, and since we had so many patients complaining really about these sort of things, the medical industry, the medical technology had to evolve, and basically what came out of it was the Watchman. The Watchman is a one-time implant that doesn't need to be replaced, performed in a cardiac cath lab by a heart team. It's through the vein in the leg, does not require open heart surgery, general anesthesia for about an hour's time, and usually 1 to 2 days in the hospital. This is called the Watchman Flex. I've been involved with the Watchman for approximately 7 to 8 years and have done hundreds of these procedures. And this device, when it first was released, was not in this shape. It was actually a little bit larger, some sharper parts of it. And I'll tell you something, it was a little bit challenging in some patients. So the device evolved. And now the way it is, it actually can be placed in the vast majority of patients. I would say well on to 99% of patients that come to me now who will request the device or need this device can get it. On the left is what we used to put in. It's the old Watchman with those struts on the bottom. You can tell that they're not necessarily sharp, but they're definitely sticking out. Look at the right, it looks like a ball. So it's become safer to implant this device in patients. And it's actually become more wider in certain points, so it's easier to put into the anatomies that before we couldn't have placed this device. When people ask me, well, has it been researched? I will tell you it is the most studied atrial occlusion device out there by far. Why? Because the FDA was hammering the company, Boston Scientific, to make sure the device was safe and effective. To put it in perspective, our surgical colleagues have been ligating or cutting off the left atrial appendage in open heart surgery when they're doing open heart procedures for decades. we didn't really have data there, but we were assuming that the clot came from the appendage, so the surgeons were saying, well, we're in the heart, we'll take that appendage out, and we'll go from there. We didn't have hard data, but we went with it because we knew that's where clot forms. Irrespective of that, this device had to go through a ton of clinical trials, and rightfully so. This these slides shows you a number of the major studies, which shows you that the device was used in 500, 700, and all up to over 2,000 patients to prove that it was safe and also effective in preventing stroke, mainly the stroke related to bleeding, because these patients were then off blood thinners after the device was placed. So the big issue here with the Watchman is it protects one particular area of the heart. It doesn't protect your carotid arteries, it won't protect your aorta, it won't protect other sources of clot in the body. Hence, blood thinners are systemic. The Watchman is localized. So why would someone then do the Watchman instead of the blood thinners? Again, if you cannot tolerate blood thinners or you have real bleeding risks because of them, this is a suitable alternative because the vast majority of clot is addressed with this device. What we've seen, common sense really, you put the Watchman in, you get someone off a blood thinner, guess what? You're going to see a drastically reduced amount of bleeding risk, 72% of less bleeding from major bleeding over a 6-month period. Now, I will tell you, stroke is only protected if you have systemic therapy. There is going to be strokes with people with Watchman who get it from other sources in the body. But remember, Watchman is not offered, and I do not do this, and it would be unethical for me to tell any patient that, sure, you don't like a blood thinner, let's put a Watchman in. That's incorrect. If you can tolerate a blood thinner, you need to stay on it. That is the #1 gold standard for systemic clot prevention. If there is an absolute reason to get you off the blood thinner, then this becomes a viable option. So it's important to keep that in mind because, again, at the end of the day, the blood thinners are still the #1 option that we all utilize as a first-line therapy. Again, the Watchman is the most studied device with long-term clinical data. So I want everyone at home watching to understand that this is not just a fly-by-night, approved by the FDA, let's put it on everybody and see what happens type of device. Again, I've been involved with this going on, like I said, 7 to 8 years. And I will also tell you that in the state of Colorado, there's about 8 or 9 different sites that perform the Watchman, including the university and other major hospitals. But I'm actually the only proctor for the company in the state of Colorado. That means that I've gone around nationally training physicians to implant these in patients all over the country. That's how much I do believe that this device helps in patients who cannot take blood thinners who have AFib. So who then gets it? And I'm going to be honest with you, I probably on average see 10 to 20 patients a week who want to get the Watchman, but just because they don't like a blood thinner. I hate to break it to you folks, but that's not going to work. The people who need to get this device are the patients who have real trouble with taking a blood thinner. Now there's 20 different categories there. If you're someone who basically says, hey, I've had nosebleeds, I've had frequent GI bleeds, I can't keep taking this medication, we'll talk. If you're a patient who basically says, hey, I've fallen 5 times in the last few months or last year, I'm scared out of my mind that if I fall again on a blood thinner, I could basically have a major intracranial or intrathoracic bleed. If you're someone who says, hey, I can't afford the NOACs and I can't take the Coumadin or warfarin because I live in an area where I can't check my levels, that would be something we should discuss. If you tell me you're a skydiver and you can't take a blood thinner because you're worried about if your parachute doesn't open, you'll have a bleeding issue, that's not going to help you. If your parachute doesn't open, I don't care if you're on a blood thinner or not, nothing's going to help. So that's not an issue. But I will say at this point in time, the realistic view of this is lifestyle does play a role if you are, say, working with heavy machinery or, say, knives and scissors, sharp objects where you will bleed at work. I've had actually industrial individuals who work in machinery or farm work who come with major bleeding all over their arms because their day-to-day work. That's an issue of lifestyle that we would talk about. So we need to have an appropriate rationale to seek a non-pharmacologic alternative to warfarin, Coumadin, or the NOACs, and take into account the safety and effectiveness of the device compared to the blood thinners. History of major bleeding, like we talked about, experience with the blood thinners, inability to maintain the INR, inability to comply with the monitoring, or a medical condition, occupation, or lifestyle placing you at high risk to trauma. So when people ask me, patients will often say, well, will Medicare cover this? So Medicare will cover this 100% as long as we meet the criteria that's laid out here, that your risk score is 3 or greater, that you are suitable for some blood thinner medication, warfarin or even Eliquis or any of those medications for 45 days after the procedure. And you have a documented evidence that you have trouble taking a blood thinning medication. So again, Watchman is a safe, effective, one-time procedure for appropriate patients. And again, it's one of those where at this stage of the game, if there is any patient out there watching right now who is told, don't take a blood thinner because you're just too high risk of bleeding or of some sort, yet you have AFib, I don't want to say it's a ticking time bomb, but the truth is if you have AFib and an elevated CHA2DS2-VASc score, there's always a risk for stroke. So we really want to be proactive with patients like this and say, hey, let's talk. Let's figure out, is there a plan that we can help you with to get you through this next phase? And with that, I want to show you the implant of the Watchman. So that's the Watchman Flex that's currently available. Its shape actually comes out as a ball before it gets deployed into the heart. There is no more steel barbs that are sticking out, rather they're pushed in. So this is why it's a much safer device than what we used to have. The sizes are much larger in range, smaller to larger, so we have a wider variety of patients that we can choose from here at this point. Again, safety is key. Number one is do no harm. And you see the implant success is nearly 100%. So the catheter goes through the vein, it's called the common femoral vein. We then go up to the heart, where we perform something called a transeptal puncture. You do not feel this, but this is something done under anesthesia. We place the catheter in the left side of the heart and put a wire into that area. We then exchange out for the Watchman sheath. We place something called a pigtail catheter into what you see in front of you is the appendage. And we have very fancy names for appendages: windsock, broccoli, chicken wing, fancy, extremely fancy. I'm not sure who came up with those. But nonetheless, you see that we then put the device into the appendage, inject some contrast to measure and see the exact size of it. We then pull the pigtail back and advance the device into a ball, and then slowly manipulate that into the appendage. And if we don't like where it sits in the appendage, we just retract it, advance it, and do it again. And this can be done multiple times. And since it's atraumatic, we can push the back wall of the heart and not cause a perforation. And once we deploy it, and we like where it is, we do a number of criteria called the PASS criteria. Position is the first thing. Then we look at anchor after that, and we basically make sure it doesn't tug out. We call it a tug test. Then we look at the size of the device and compare it to its compression. And finally, we look at seal. We look to see that there's no color around it. And if we are happy with that, we release. And over the next month, 2 months, the heart will actually grow tissue over the device. And this just shows you that there is reduced metallic coverage and has more of a complete seal. And that's how the heart tissue will then grow over it. I always tell people it's like placing a cork on a bottle. So with that, I'd like to say thank you, and we're going to open the floor to questions.
So to our online audience, if you give us just a second for both doctors to get to the podium up here, we'll begin our questions. And also to our audience, feel free to ask more questions in the chat box, and we will get to as many of your questions as we can this evening. So I believe these are to Dr. Anderson, but I'm going to let you guys, do your thing up there and figure this out. So what do you think of AV node ablation after ablation, a pacemaker, and beta blockers have been unsuccessful?
AV node ablation is a form of rate control. We talked about rate versus rhythm control. Rate control is keeping the atrial fibrillation from going too fast, whereas rhythm control keeps the person as best we can in normal rhythm. Some folks aren't able to undergo rhythm control. Either they've tried antiarrhythmic medications and they haven't worked, or they've had toxicity from them, and they may not be able to undergo an atrial fibrillation ablation, which requires general anesthesia and carries some risk with it. And some people are at much higher risk of an adverse event happening from an atrial fibrillation ablation. In those cases, and if they've also tried controlling the heart rate with medicines and either their blood pressure has dropped too low or their heart rate is very slow, none of those strategies may have worked. In that case, we will offer people AV node ablation with a pacemaker. So that's 2 procedures, each of which takes approximately an hour, where first we put a pacemaker in, which is a small device that sits in the chest under the collarbone and away from the shoulder, and where we snake a wire into the top chamber of the person's heart and another wire into the bottom chamber of the person's heart. And those wires are connected to the small pacemaker that gets tucked under the skin. After that's in place, we do a simple, straightforward ablation that does not require general anesthesia or blood thinning during the procedure or a lot of monitoring during the procedure, where we simply heat one small area of the heart to prevent the chaos of atrial fibrillation in the upper chamber from making its way to the lower chamber. That will render someone dependent on a pacemaker. That pacemaker will then keep the heart from going too slow or too fast, and the heart will always beat in a regular way as opposed to irregular in atrial fibrillation. It's an excellent treatment for controlling symptoms. About 98% of people have control of AFib symptoms. But it also has its limitations. Some people, if a person's heart starts off as weak, giving them a pacemaker and making them dependent on it can further weaken the heart. In those patients, we either avoid doing AV node ablation with pacer, or we can give them a fancier pacemaker that can prevent the heart from weakening or correct a weak heart if that happens. So it is a nice therapy. It's used in people who have tried and failed other treatment options, and then it's a form of permanent procedural rate control.
Thank you very much. Is there a connection between mitral valve prolapse and AFib?
So it's interesting that mitral valve prolapse was a condition that we have seen maybe 60, 70 years ago, a lot of patients being diagnosed with. So the truth is mitral valve prolapse per se may not be a direct relationship to an arrhythmia, but mitral regurgitation, which may occur from mitral valve prolapse, which basically means leaking of the valve, can cause that left atrium, which is the chamber that's connected to the left ventricle where the mitral valve connects the two, can cause arrhythmias to develop. So when you have significant leaking of the valve and it causes the left atrium to dilate, that type of change in the anatomy of the atria distorts it, and that lends itself to developing arrhythmias. So there's often times where we talk about MR, mitral regurgitation, begetting AFib versus AFib begetting mitral regurgitation. It's one of those where it's kind of a vicious cycle. So per se, a prolapsing valve doesn't necessarily cause arrhythmias, but rather if there's leaking associated with that prolapsing valve, there is a higher likelihood of some arrhythmias potentially developing.
Thank you. Is there a relationship between AFib, bradycardia, and or trachycardia?
Is that bradycardia, tachycardia you're asking?
Probably.
Got it, yeah.
So tachycardia is just a term, it's Greek for fast heart, tachycardia. And that simply means that a person's pulse is 100 beats per minute or more. That's how we define that. There are many, many types of tachycardia. Bradycardia is Greek for slow heart. And that is when the heart rate is less than 60 beats per minute. Now, that's just the heart rate. There are many different ways in which the heart can go slowly or the heart can go fast. And in atrial fibrillation, the top chamber of the heart is going very fast. The bottom chamber can then go, it's always irregular. It can be irregular in a normal heart rate, irregular and a rapid or tachycardic heart rate, or irregular and slow in some folks, so irregular and bradycardic. So that's the definition of brady and tachycardia.
Okay. Can you briefly explain again what beta blockers are for?
Beta blockers are medications that are, in the setting of atrial fibrillation, are rate-controlling medications. They do not keep people from going in and out of atrial fibrillation, and they do not get people out of atrial fibrillation. But when people go in atrial fibrillation, beta blockers can be used to slow the heart's response. So if people go very rapidly in atrial fibrillation, their pulse is very fast, beta blockers like metoprolol, the most commonly used one for this, can slow that response down. The other medication that's used for rate control in that way is calcium channel blockers such as diltiazem. So they are rate controlling medicines for atrial fibrillation. Both of those medicines have many other purposes. They can be used to treat high blood pressure. Beta blockers are also used to treat chest pain and prevent heart attacks in some people. So that's their role in atrial fibrillation, is to slow things down.
Okay, thank you for that clarification and to reiterate that. Thank you. Are there any homeopathic products to decrease AFib?
So I'm actually board certified in lifestyle medicine, which is using evidence-based lifestyle changes. So things you can eat and drink and do for yourself, like exercise, etc. And while, as we mentioned, there are many, many lifestyle measures that one can take, especially eating a whole food plant-based diet, avoiding alcohol, quitting smoking, and exercising that just right amount and getting good sleep, there aren't products that are shown to be helpful. But you can get all the nutrients you need and all those substances you need to decrease inflammation and decrease atrial fibrillation through a healthy diet and exercise and optimal sleep.
But no supplements that you know of that are helpful in that respect
either? Right, there
either?
aren't products that one can buy to do that, but there are many, many actions that people can take, as we've discussed.
Okay. Are the home monitoring devices reliable and useful to detect AFib?
just going to stay standing up here. Yeah. There are many home monitors that are very useful. An Apple Watch, for folks who have that, can get the most recent models of Apple Watch can generate an EKG strip. And while the algorithm it uses to interpret those is imperfect, the tracings are often very high quality. And so folks who have an Apple Watch with the ability to generate an EKG strip, my AFib patients with those, I will have them send them to me. It's quite easy to do so through the medical record, and I find them quite useful. Other devices, there's a device called a Cardia device with a K, K-A-R-D-I-A, that couples with an app on a person's phone and also can give a very high quality EKG tracing, and those tracings can be sent if people think, oh, I think I'm in AFib, I can take a look at those and give them advice. A very simple device that works great is a pulse ox. You can buy a pulse ox at any pharmacy, and it's that thing that you put on your finger, and it will measure the pulse or heart rate and your oxygen levels. In atrial fibrillation, the pulse is never regular. It is always irregular. So if people put a pulse ox on and the heart rate part of it is all over the place, it gives you, it says 110, 135, 142, 96. Over the space of, 10 seconds, that's often a sign of atrial fibrillation. So those are very useful devices for people, the least expensive of which is a pulse ox.
Thank you. Is there a connection between mitral valve prolapse and AFib? What about pacemakers?
So I think Dr. Iyengar just addressed the mitral valve prolapse and atrial fibrillation a couple questions ago. And pacemakers are used in atrial fibrillation if the heart's response to the atrial fibrillation is very, very slow, or as we talked about, in combination with an AV node ablation for permanent rate control.
And I just want to comment too about the pacemaker. For everyone who has one, the pacemaker keeps you in a regular rhythm, but that doesn't mean you don't have potentially atrial fibrillation as well. So if you have a pacemaker and a history of AFib and you feel your pulse is regular, that doesn't tell you that your AFib is cured. It's just that your pacer is doing the work and keeping you regular. So it is something I would like everyone who has that condition to talk to their physician about, to clarify, so they're not confused that a regular rhythm with the pacer means no AFib.
And that's also true with an AV node ablation and a pacemaker combination. That is, as I mentioned, a rate controlling treatment. It doesn't get rid of the atrial fibrillation. The top chamber will still fibrillate. And that's very important when people say, oh, if I get this AV node ablation with a pacemaker, does that mean I don't have to take a blood thinner, or I'm no longer at risk for stroke? And unfortunately, the answer to that is no, it doesn't. We really use that CHADS VAS score to determine people's risk of stroke. And if it's 2 or more, or in many cases now 1 or more, we offer a blood thinner regardless of what other treatments we can provide to treat the symptoms from AFib.
So in effect, there may be multiple treatments, not just a pacemaker then?
Yes, there are multiple treatments for atrial fibrillation, yes.
Okay. Used simultaneously, I guess.
Often used in tandem. We'll do one thing and try another thing, and yes, so there can be a variety of combinations of treatments.
How does COVID diagnosis affect AFib?
Sometimes COVID affects the heart. The illness of COVID can cause inflammation of the heart muscle. It can cause dilation of the heart muscle, and it can create inflammation of the lining of the heart, or pericarditis. And any of those things can then trigger atrial fibrillation. Many illnesses can trigger atrial fibrillation, and it doesn't necessarily predict that the person's then going to have atrial fibrillation forever. So we do monitoring to see how people do once they've recovered from COVID or any other infection.
Does low platelet count make bleeding risk from blood thinners even higher?
Yes.
Okay. What material is the Watchman made of?
So the Watchman has basically we call it nitinol, a nickel titanium frame with the mesh that's on top of it. Realistically, it is something that I've never seen a person have an allergy to. However, if someone does have nickel allergy, which is probably one of the more common metal allergies, we would oftentimes have the patient undergo an allergy test with an allergist prior to putting the device in. So these are important things to talk to your physician about prior to any procedure that's going to implant a device, whether it be a knee replacement, hip replacement, a Watchman, or a stent. If there is a metal allergy in the history, or even if you think there may be, and I'll just tell you, for example, if you said you had earrings as a child and had a reaction, that's a person I would still make sure you get an allergy test prior to putting this device in. So basically, the ingredients of the Watchman or the makeup of it is quite inert. And again, I've yet to see, knock on wood, one patient that has had a rejection of the device. But that being said, if there is any history of metal allergy, definitely get checked before.
Is there an alternate Watchman that's not made with nickel in some of these things?
There is not. So normally if a patient as 100% cannot get this type of implant, we would oftentimes have them see one of my surgical partners, Dr. Mahan or Dr. O'Hare. They can do something called an atrial clip procedure where they clip the appendage, but that is much more invasive than the Watchman. It does require a semi-open procedure on the side of the chest. So that is not something we oftentimes use if we don't have to.
Thank you for that. How long does it last?
So the data on the Watchman, again, is out nearly, say, since the original trials in the late 05, 06 time, permanently. We have never seen a Watchman not work because the heart absorbs it over time. So there's not like you're going to see a hole develop in the middle of the Watchman. Theoretically, the body should absorb this if it is placed correctly. Now, there are people who have Watchmen that have leaks around them. Well, I would argue the right device should have been placed. So that's why we strive for having the device that's going to be perfectly seated in the appendage, theoretically then having the body absorb it. So at this point in time, there's no such thing as a replacement Watchman as time goes on.
What about the older ones, though, that didn't have the closure on the ends?
They are fine as well because those closures at the end have no bearing on the face of the device. That was all into the appendage. They have no relationship to the face of the device. The device on the face, same thing. It would get covered by the heart as well.
Okay, thank you. What is recovery after ablation?
For an atrial fibrillation ablation, the recovery is about 3 days or so. Most of the recovery is allowing the IV sites into the femoral or leg veins to heal up. I use a closure device so that people don't have to lay flat for 6 hours after. They can get up as soon as they're awake from the anesthesia. And that helps healing of the sites as well. And then we just tell people for about 3 days after the ablation to take it relatively easy. Even that day, they can get up, walk around, go up and down stairs if they needed to, but not to do any vigorous weightlifting or that kind of thing. There's not really healing in the heart that has to take place to allow for recovery from atrial fibrillation ablation.
Okay. What is the intensity of exercise a patient should be doing? Is there a heart rate range, or is it specific to each patient?
From an AFib and general cardiovascular standpoint perspective, the amount of exercise, as we talked about, that's considered ideal for reducing risk factors for heart disease and preventing trouble from too much exercise is about 150 to 300 minutes per week. And it still holds the traditional advice that working to reach 85% of your maximal predicted heart rate, which you can easily find that if you Googled that, there's a variety of charts. Often gyms have those charts, and that is determined based on your particular age. And you want to reach that 85% predicted of your heart rate for a good chunk of the, say, 10 minutes of the exercise, 12 minutes of the exercise you do in any given day.
Is there a website, again, that you referred for that?
No, if people wanted to know their maximal predicted heart rate and then determine 85% of that, they could simply type that into Google. Like, what is my goal heart rate for exercise? You could find an answer. I'm sure there are a variety of websites that give that information.
Perfect. Is there an upper age limit for having a Watchman implanted?
So there is no age limit, or shall we say that there is no, I don't look at age as being ever the criteria for Watchman. It's included for the CHADS-VASc score, but when it comes to getting the device, I oftentimes say to patients, it's really the person, the brain, the willingness to get better and to be active. Because you know what? There are patients who are 90, 93 years old who are outside every day and have said to me, I cannot have a stroke. There's no way I am too active. And you know what? Absolutely agree. But there's patients that are 70 or something that are bedridden who honestly are not patients who really are having that lifestyle, who have said, you know what? I don't do much to begin with, and honestly, I'm not sure. I could probably just take a blood thinner because I don't get out of bed that much. And it really does come down to the individual, not the age. It really comes down to what the activity of the patient is and the person. Because again, as we said before, the Watchman's indicated for patients who have trouble taking blood thinners. So realistically, if someone really didn't have a problem with it and they just don't like it, the Watchman's not indicated for you. It's indicated for those who actually have a problem with the blood thinner. So age isn't the cutoff, it's really the person and the risk score.
Is it safe for folks with AFib to donate blood?
AFib itself shouldn't prevent a person from donating blood. There may be restrictions on people on blood thinners, though. And the vast majority of people with AFib have enough risk factors for stroke that we recommend long-term blood thinners to prevent stroke. So in that setting, and as with other blood thinners, they wouldn't be able to donate blood.
Okay, thank you for that clarification. When a patient is being monitored via telemetry device or in the ER, can you see the AFib events?
Yes, that's a form of EKG monitoring, and we can see AFib on telemetry. Yes.
Okay. So this is a personal question from someone. They said, I've had an ablation 6 years ago. My AFib is well controlled with maybe 3 to 4 episodes in 7 years. Why do I need to continue to take Eliquis?
That's a great question. So unfortunately, a person's risk of stroke is not related to whether their AFib comes and goes, whether they're in AFib all the time, their heart rate in AFib, their symptoms in AFib, or the length of time or number of episodes of AFib that they have. The factors that are shown to associate the presence of AFib with stroke are those CHADS-VASc scores. So for example, someone who is 75 with high blood pressure, who's a woman, that adds up to, it turns out, a stroke score or CHADS-VASc score of 4. So they're at a bit over 4% per year risk of having a stroke, regardless of what treatment and regardless of how well their symptoms do. So unfortunately, there's no cure for atrial fibrillation, and stroke risk persists even if we can get nice control of the symptoms. So there are two separate aspects of treating AFib that I help people with, is preventing them from having a stroke and also keeping their AFib under control so that they don't have symptoms. But different factors go into both. So even someone, as I described, with a CHADS-VASc score of 4 who has great control with an AFib ablation, we would still recommend, because of risk of stroke, using a long-term anticoagulant.
Kind of a segue to that, is there a cure or any research in process for AFib?
So there is not a cure for atrial fibrillation.
Okay. What are the reasons for not using the Watchman when the ablation is being performed?
So this is an interesting question. I get this quite often. I think your question that the viewer just asked that, hey, I had an ablation 6 years ago and I've only had a couple of AFib episodes. Why am I taking a blood thinner? And I get this question a lot. And actually, the way we kind of approach it is that the ablation is for symptomatic relief of the atrial fibrillation burden, to make you feel better. Patients who have AFib and have symptoms, the ablation treats those symptoms. However, the AFib can return in different ways, like this prior individual said. It may come back in other ways, maybe only a few minutes, an hour, who knows, here and there. You might not even feel it when it comes back. However, as Dr. Anderson mentioned, the truth is, if you do have AFib and it comes back, even if you don't feel it, it can still cause a clot to develop. So hence, the ablation is meant for symptomatic relief of your atrial fibrillation. The blood thinners are there in case you get that asymptomatic AFib or even symptomatic, but if you don't feel the AFib, the risk of stroke is real, especially if you have an elevated CHA2DS2-VASc score. Hence, most patients who get ablations will stay on blood thinners indefinitely because of that reason. And that's important because a lot of people will say, if I don't feel it, how is it causing a problem? And that's where I will tell you, we see a lot of patients in the ER with strokes who never knew they had AFib, and when they're in the ER, they have it on the monitor, or they don't, and a month later we see it on the monitor that we sent them home with, that it picks it up. So keep that in mind, that just because you don't have symptoms, you can still have the risk of stroke with AFib.
What is the difference between a flutter and AFib?
Atrial flutter and atrial fibrillation are two different but interconnected rhythms. In atrial flutter, the upper chambers beat, but they beat very fast, around 300 times per minute. The lower chamber won't go that fast, perhaps half as fast, 150 beats per minute, or some fraction of how fast the top goes. In atrial fibrillation, the upper chambers are utterly chaotic and not truly beating. They're just shaking chaotically. Now, people who have atrial flutter is generally a curable rhythm with an atrial flutter ablation. But anyone who's ever had flutter, it can be a stepping stone and a predictor of future atrial fibrillation. So when I have a patient who has flutter and I'm able to cure it with an atrial flutter ablation, I always let them know, this flutter is not likely to ever recur, but you are at risk for future development, say 5 years, 10 years, who knows, of getting atrial fibrillation. So I let them know to be on the lookout for recurrent symptoms of either irregular beating or palpitations or that kind of thing.
That's a nice clarification. Thank you. What reversal agents are available for Eliquis or Xarelto?
So there are available agents that multiple emergency rooms carry for these agents. However, they're very expensive. And the problem is not every emergency room carries them, because it's usually what it comes down to is the population of the hospital, if it's rural versus city versus community. We do carry reversal agents for Eliquis, and I will tell you that the reversal agent for Coumadin or warfarin, which is vitamin K or FFP, are readily available. Hence, when patients have a bleed with warfarin or Coumadin, I would say the vast majority, if not all hospitals in the US, will be able to reverse them quite quickly. So in a way, it's a double-edged sword. You're dealing with these new medications which are really cutting edge, and you can eat what you want and you don't have to check your levels. The problem is, if you're somewhere and you have a bleed, that emergency room potentially may not have that reversal agent. And that is something that patients have to really understand. And that's one of the drawbacks of having these new medications available.
That said, at Boulder Community Health, we carry PCC, which is protein complex concentrate, which is a reversal agent for apixaban, and which is Eliquis and rivaroxaban. which is Xarelto.
Does it usually go into effect immediately then?
It does work quite quickly, yes. I, not too long ago, had to give that for someone who had an injury while they were on Eliquis and needed a surgery as a result of the injury, and we were able to very quickly get PCC, and the bleeding was able to stop very quickly.
Thank you. If persistent AFib is a normal consequence of episodic AFib, how frequent severe events are considered sufficient to explore ablation?
Atrial fibrillation that is highly symptomatic and has generally failed at least one rhythm drug is amenable to ablation, depending on how well the patient might be able to withstand the ablation procedure. Most people can safely get through an ablation procedure, but again, it's done under general anesthesia and there are some risks, so it's not a procedure for everyone. So people who are have a lot of medical conditions, who are quite frail, who may not be able to get through general anesthesia, they may not be a candidate for it, but we do fib ablation on both paroxysmal and persistent atrial fibrillation, but we always prefer to do it when it's still paroxysmal because the results for the patient are much better. But we can certainly do it in people with persistent AFib. The results just aren't as good.
Okay. We have time for just a few more questions here, and then we'll wrap this up for this evening. Dr. Anderson said AFib can cause anatomical changes. To diagnose an irregular pulse, is there imaging that can be done in addition to ECG, maybe EKG?
Well, the electrical signals are what we use to diagnose atrial fibrillation. So we use electrical signals that we can capture with EKGs, or pulse oxes can give us an idea that we need to look at an EKG, or monitors that people wear that give EKG tracings, or even on those Cardia apps or an Apple Watch, we can diagnose atrial fibrillation, but it's diagnosed based on the appearance of the electrical signals, and so some way of capturing electrical signals is what we use.
Okay. Is the Watchman an option for atrial flutter?
So atrial flutter and fib are just, again, kind of cousins of each other in the arrhythmia spectrum, but atrial flutter, as Dr. Anderson had mentioned, tends to respond quite well to the ablation procedure and is a more, I would say, maybe less intense than an AFib ablation. So if there's a reason that the patient is in atrial flutter and cannot be converted over to a normal rhythm, or they go back and forth between aflutter and AFib, then yes, the Watchman would be indicated if they cannot take a blood thinner long term, because again, atrial flutter and atrial fibrillation are both conditions where we would suggest being on a blood thinner. So if there was a reason this individual could not take a long-term blood thinner and the flutter for whatever reason wasn't being treated, then obviously, yes, I would definitely consider that patient for a Watchman implant if they were anatomically suitable.
Okay. This patient is on warfarin and they've been asked to stop taking if they have dental or dermatology procedures. Does that seem appropriate?
Well, I'll tell you, that's a question that I would have to sit in front of the patient and talk to them, because just for the information that you've just said, I can't tell you yes or no, because it really comes down to the history of the patient. Example, if a patient is on Coumadin or warfarin but had a stroke in the past, I would potentially bridge them with something called Lovenox, which is an injectable anticoagulant that a patient can give themselves for a day or two to get them through a procedure, and then retake their medication after with the bridge with Lovenox. If this patient has a CHADS VAS score of 1 or 2 with no history of any stroke, well, we've also held the Coumadin on those patients and let them get their dental procedures and then restarted the Coumadin afterwards without any issues. So it really is an individual issue. I have to look at the patient's background and what they've gone through prior to making the decision that it's okay or not okay to just hold the medication.
Okay. Can you discuss the effects of lifestyle changes that you've suggested, such as the weight loss and limiting your alcohol and caffeine reduction to mitigate the AFib symptoms versus taking a medicine?
They often may need to be used in conjunction with one another, but I certainly have patients who come in who've, say, had 1 or 2 atrial fibrillation episodes. And at that early stage, lifestyle alone, those changes such as making sure you get 7-8 hours of sleep, losing excess weight, avoiding alcohol, quitting smoking, and eating a whole food plant-based diet, that is shown to decrease the AFib burden and the progression of episodic or paroxysmal AFib to persistent AFib. And there are actually studies that some folks can have their persistent AFib go back to paroxysmal if they're able to go all in on lifestyle change. So medicines and procedures and lifestyle are not mutually exclusive of one another, but are often complementary.
Thank you. Thank you to the doctors tonight. We appreciate all of the presentation as well as the Q&A. Thank you very much. We've come to the end of our time. A recording of tonight's lecture is available at bch.org/livestream. You will receive a post-lecture survey by email. Please take a minute to fill this out. Again, please visit bch.org for information on the COVID-19 vaccine. Thank you for joining us, and have a good night.